robotic technology is going to help man to achieve better outcomes. So in this, the Navio was used for this study. So as you can see, the robot will act as a friend, not superior to the man. So the surgeon is the ultimate thing that will do the surgery. Robot is going to help him. So why use the robotic arm? Malalignment in coronal plane has been reported to be an important factor for revision TK due to increased chances of prosthetic loosening. An axis deviation of more than 3 degrees significantly increases the risk of TKA failure. Many studies have shown that using a computer-assisted navigation significantly reduces the mechanical axis outliers as compared to conventional jig-based technique. So, robotic-assisted TK is an extension of computer-assisted surgery, which uses this robotic arm and the computer navigation technology for executing TK. These systems have the potential to dynamically assess the soft tissues over the range of motion and also the ability to use the haptic control in bone preparation. So what was the purpose of our study? Moon et al. In their cadaveric study showed that robotic TK is superior to conventional TK. But at that time, there was no level 1 published study using the handheld semi-active robotic system comparing the conventional TK and the robotic assisted TK. So the aim of the surgery was to compare the post-operative radiographic implant positioning and joint line between conventional jig-based total knee arthroplasty and robotic assisted TK. So the method study period was from April 2019 to March 2020. Sample size was of 60 patients, out of which 12 were male and 48 female. A prospective randomized control study was done. The allotment was according to the computerized generalized randomization. Varus deformity was defined with the HK angle more than 3 degrees and the mechanical axis passing medial to the knee joint. Pre-operative and post-operative radiographic measurements were done, and also post-operative CT was done to assess the femoral component rotation. The statistical analysis method that was used was a two-sample test was done to compare the mean and standard deviation between the conventional group and the robotic group, and the statistical significance was set at p-value less than 0.05. So what were the exclusions? The inclusions were unilateral patients with mild to moderate varus deformity, but the exclusions were those with a severe deformity with more than around 15 to 20 degrees of varus deformity, inflammatory arthritis, the ones with post-traumatic arthritis, valgus knee, and a pre-existing symoid hip pathologies. So the operative technique, medial parapatellar approach using PS design implant Anthem. Then major resection philosophy was kept to achieve a neutral mechanical axis alignment. Conventional technique was done using a jig based to achieve equal flexion and extension gaps, and robotic TK using the semi-autonomous handheld Navio. So what were the radiological measurements that were done pre-operatively and post-operatively? So the hip knee ankle axis, this was the angle calculated between the mechanical axis of the femur and the mechanical axis of the tibia. Then the femoral coronal alignment is the angle formed between the mechanical axis of the femur and the tangent drawn to the distal, medial and lateral femoral condyles. Then the femoral sagittal alignment, which gives the flexion of the component or the femur. This was done using the mechanical axis in the sagittal plane and the perpendicular drawn to the tangent to the distal most portion of the femur. The femoral component rotation pre-operatively CT was not done, but in the post-operative the femoral component rotation was done using the radiographic transepicondylar axis and the angle between the femoral condylar line, the posterior condyle. Then the tibial coronal alignment was the angle formed between the tibial mechanical axis and the perpendicular line along the base of the tibial base plate. The tibial slope was the line between the anatomical axis in the mechanical axis in the lateral view and the 2 points joining the anterior and the posterior most point. And for our study, the joint line distance was calculated using the tip of the fibula as the fixed bony point. So these are the diagrammatic representations. So in our study, there was no demographic dependence either on the robotic or the conventional. There was no significant statistical implication with age, gender, BMI, weight, or the site specific. But coming on to the main factors, there was a statistically significant difference which can be seen in the mechanical axis alignment post-operatively, then the femoral coronal alignment, tibial coronal alignment, and the joint line deviation in the conventional TK versus the robotic TK. So there was a significant difference that can be noted. The joint line deviation in the robotic group, the mean was around 0.9 mm, while that in a conventional group it was around 3.5 mm deviation from the normal side. Then coming on to the discussion. This is a novel imageless semi-autonomous robotic system which was able to achieve planned mechanical axis and prosthetic component positioning with fewer outliers. Then Chung, Song, Ren et al. In their studies showed that robotic assisted surgeries are more capable of improving the mechanical alignment and prosthesis implantation. There is a good correlation between neutral mechanical axis and a good knee function. Jeffrey et al. In their study of a post-operative study on 115 knees showed that alignment less than 3 degrees has a 3% incidence of loosening at 12 years, while alignment more than 3 degrees, there is a 24% incidence of loosening at 8 years post-op. Song et al. In their study on 30 patients showed that the robotic assisted TK has significantly better alignment than a conventional TK. The joint line position alteration leads to increased patellofemoral forces, anterior knee pain. More than 2 mm deviation leads to decreased knee flexion. A systematic review reported a maintained joint line leads to a better post-operative knee society score. So what were the limitations? This study was just a radiographic study comparing the pre-operative and post-operative radiographs. This does not evaluate any clinical outcome. There is a possibility of human error in radiographic calculation. Difference in the operative time and cost-benefit analysis of use of RTK versus the conventional was not considered. So to conclude, robotic assistance is highly accurate with respect to achieving better coronal plane component positioning and mechanical axis alignment. Also, the joint line is better restored with robotic assistance. That might be helpful for a better patellofemoral kinematics. These are some papers to support. These are the references. Thank you.